So I believe this is your first time presenting in year two. So I'll let Eric introduce himself, but you should know who Eric is if you've read a research paper or attended an ICE course in recent history. He teaches down University of St. Augustine. He teaches our extremity management course. So this is the first of a couple of extremity-based lectures that he'll be giving this year in Vice, starting with ACL rehab. So I'll let you take it away, Eric.
Thanks, Alan. So yeah, I did. We in year one we did a couple different knee topics, and I sort of felt like we really left a big gap in the athletic knee, particularly ACL. This is one of those ones that a lot of people will see 1, 2, or 3 ACLs a year. The people that are seeing lots and lots and lots of ACL reconstructions and have lots and lots of experience in this with this condition, probably won't see this as valuable, because some of the ACL stuff is really just comes with experience. I'm going to give you guys a bunch of resources as well, and really talk about prevention. I think those of you that are in, as I was developing this recently, I really thought about those of you in the prevention space, or those of you that are wanting to get into the prevention space a lot. So when it comes to population health, I think what you have here is an incredible opportunity. And I'll show you that. There's a lot of underserved, our youth sports population is actually incredibly underserved when it comes to knee injury prevention programs, despite tons and tons of literature and examples of where these prevention programs work really well. So we'll go ahead and get started. All right, fairly prevalent knee injury, actually. You can see the numbers there. $1 billion in healthcare expense per year. That's in the United States. Obviously, we lead the world in surgical repairs for the ACL, as well as cost. And our primary demographic that we really have to look at when you look at this condition are the adolescent, high school, and college athlete, with the female athlete being the one who's actually much more affected at a much higher rate. So you can see that there. Over 3 times more likely to occur to a female athlete compared to a male athlete when you control for the sport, same sport, and all that. Soccer and basketball seem to be the sports that kind of lead the list. It's going to depend a little bit based on where you are in the country and the popularity of the different sports in the country. So we see in the Northeast, lacrosse and field hockey as another one with high prevalence. And the 3.8% relative risk, that's the level of risk that a female athlete can expect when they step on the field per sport season. So when you look at an athlete who plays 3 sports, a multi-sport athlete, or an athlete that plays a single sport but year-round, right, has off-season leagues and travel leagues and stuff like that, that can amount to almost a 10% level of risk per athlete, which is astonishingly high. So this is one of those conditions that we really do need to be incredibly aware of the prevention model, just because risk levels are what they are there. The MOI, and part of the reason why that that female athlete is at such high risk is the non-contact pathomechanics when it comes to landing and cutting techniques. So one of those with both landing and cutting, everybody's very aware of the hip adduction, kind of knee valgus movement that can occur. When that occurs in an excessive manner and the athlete's unable to control the limb, that's one way to get the injury. When it comes to landing, it's that same issue, with oftentimes the trunk out of position, so the trunk being in side flexion or flexion outside of the base of support. And the big one is the stiff knee landing. So you really want a nice healthy co-flexion of the hip and knee as you land, and that doesn't occur oftentimes for some of these athletes, and that's why you get that stiff kind of knee landing. So think of it as like we need to teach soft landings, right? We need to teach soft landings. When we land with a stiff knee, then that is what increases that ground reaction force. So when you see 20% higher ground reaction force, that's really because of the lack of hip, and knee flexion. When somebody tears their ACL, they are automatically at a much higher risk even after a successful surgical procedure, successful rehabilitation. And I want you to think of that as a central process. That's really important because the emerging literature shows us that really they are just as likely to tear the contralateral limb as they are the involved limb that had the repair. So it might not be the graft weakness, or any local factor in that involved limb, maybe central factors, right? Central factors, hormonal factors, central nervous system factors, fatigue factors, structural factors. There's a lot there. Fear is another topic that's important as well, kinesiophobia. So that's important to remember, right? When this athlete is done with you and has a successful rehab, getting them in the hands of a good strength and conditioning coach, having a good strength and conditioning program and ACL knee injury prevention program is really critical. One of the big issues is return to sport rates still being very low. That's in the amateur athletic population. In professional sports, those numbers are much better. But when it comes to high school and amateur sports, return to sport rates are still very low at 50%. And then the big issue is the long-term health of that knee, right? That's what you're really worried about. As a physical therapist, when this patient injures their knee, whether they have the surgery or not, you have to constantly have in the back of your mind the likelihood of them developing osteoarthritis is very, very high. We want to make sure we protect that knee and get that knee as healthy as we possibly can to hopefully mitigate that. But like I said, it doesn't seem to matter whether they get the surgery or not. The likelihood of them going on to develop knee OA is pretty high. So that's kind of inherent in the injury. I'll talk about some of these concomitant pathologies. It may be, the associated bone bruise. It may be the associated meniscus damage. But either way, this injury definitely beats up the knee from a long-term perspective. We got to start thinking about prevention programs. It's amazing how few prevention programs exist. It's amazing how few high school and amateur athletic programs incorporate prevention. So you as a physical therapist in your local community really play a critical role in bringing this information to the community and to the sports team. So I think, like I said earlier, if you're looking to incorporate prevention into your practice, this is an incredibly great place to start because it's really, really easy. I'm going to show you some of the programs that exist. They're so simple, and the earlier the better. The earlier the better. You'll hear of prevention programs starting in the 5th grade, as young as 5th grade. So pre-adolescent and early adolescent is really a critical time to begin to intervene. You want to start teaching landing patterns, teaching strength and conditioning principles in that population. So this is intended, I'm going to give you guys all the PDF of this talk so you'll have access to all these links, but this is intended to be really a post-talk resource for you. What we know is that the FIFA 11 Plus in soccer has demonstrated a lot of good outcomes in reducing injury risk across the board. So hamstring strains, patellofemoral pain, ACL injuries. It is super, super basic. When you look at it, you're like, this is the most basic strength and conditioning program I could think of. But it's a lot of teaching landing, like I said, the soft knee landing. It's a lot of core control exercises, hip control exercises, and neuromuscular kind of proprioceptive type of exercises that you guys are all familiar with. Santa Monica has a great program that they've published. That PDF is there for you to access. That shows you the whole program in a nice handout. And then the Cincinnati ACL Prevention Program is, if any of you are really interested, take this a step further, really get serious about it. Sports Metrics is the organization, Cincinnati Children's Hospital organization. That is a certification you can actually get. They'll put you through an intensive course where you learn in great detail how to conduct these prevention programs. You learn the biomechanical model and the exercises and the evaluation screening process. That's actually developed by Noyes, the surgeon Noyes and Hewitt, Tim Hewitt is one of the other authors, and that's who published that 50% reduction. So that 50% rate reduction in ACL injuries was actually by that Cincinnati group that does that sports metrics program. All right. What if we didn't get the prevention program in place, and we unfortunately did have an ACL tear in one of our patients? Your clinical exam is going to diagnose an ACL injury with these three findings. So 83% positive predictive value if you see a popping sensation during trauma, or they report back when they had the injury, a popping sensation, knee joint effusion, and a positive Lachman test. So three simple findings that would be very indicative, obviously, of an ACL tear. If a Lachman is negative, it does not really mean they don't have an ACL tear. The concern there is that the knee is so swollen, you just can't feel the laxity yet. So Lachman is better than anterior drawer from a validity standpoint. I can tell you in my experience, though, I've gotten people where I couldn't feel the Lachman, I couldn't feel the laxity. I then moved them into the anterior drawer, did that test, and actually did feel the laxity. So even though Lachman's the better test, I still think you can do the anterior drawer sometimes when the Lachman findings are inconclusive. You're probably going to get an MRI in those cases, right, where there's kind of inconclusive findings, and it all makes sense and sounds like an ACL, but it's just not demonstrating that laxity when you test them. Some of the different co-occurring injuries that really do complicate things. This can make this rehab process very, very challenging and really hurt our outcomes. But tibial eminence fracture is a big one. You'll see that notch, that tibial eminence, will actually avulse when they tear the Sagan fracture. You can see the little chip there on the lateral edge of the proximal tibia. That is because of the subluxation that occurs in the knee. So when that ACL tears, that knee is going to sublux, and it'll take a little chip of the edge of the tibia off right there. And then the bone bruise is the big one. The prevalence is very, very high. And lots of our patients present with bone bruises after ACL. I've seen numbers as high as like 90% of ACL injuries with a concomitant bone bruise. So the challenge here is we've got this subchondral edema, right, in the trabecular bone of the, in this case, distal femur, and that makes weight bearing very painful. So they're going to struggle with weight bearing exercise. It's going to be harder for you to progress them. In the early weeks after rehab, you won't be able to do as many squats and single leg step ups and all these weight bearing exercises that we really want to do to gain quad control and glute control. We won't be able to because of pain. So you got to kind of calm that bone bruise down if it's present. All right, so you've diagnosed the ACL tear, and now you really need to figure out, is your patient a coper, a non-coper, or an adapter? So just because you tear your ACL doesn't mean you have functional instability. And that's of critical importance, because when somebody has an ACL tear but is able to cope, has functional stability, they may not need surgery, right? They may not need surgery. So that's good news for some people. So the way you classify them as a coper is you take them through this Delaware criteria, and this has been out for a while now. But what you're looking for basically is some degree of symmetry with the hop test. So we can do a crossover hop test. We can do a timed hop test. There's a number of different hop tests that are performed, but you basically want to see them, the two limbs fairly close to each other. The involved shouldn't have more than a 20% deficit. Knee outcome surveys, self-report measures, so is the global rating of knee function, and on both of those you want to see these scores, 80% or 60 or better scores. And then the real important one here is they should not have more than one episode of that knee giving way since the injury. So if they test negative or meet all four of those criteria, they're a coper, they may not need surgery. It's an important discussion to have with them. Surgery doesn't necessarily mean less osteoarthritis later in life. What surgery does for you is it creates functional stability so you can perform your activities. And in this case, they don't need that because they already have functional stability because they're a coper. So if they test negative, if they don't meet these four criteria and they're a non-coper, that's somebody that more than likely does need surgical repair. because that knee is never going to really be stable unless they get it repaired, and they're going to have subluxations and giving way, and they're going to fall down, and it beats that knee up, wears the cartilage down even faster, wears the meniscus down even faster, and it causes a lot of issues. An adapter is an individual who is able to just adapt their activities, and then they're okay. So they maybe were a soccer player, tore their ACL, have got some laxity there, but because they stopped playing soccer and they switched to swimming, now they're all right. Right now they can function with some degree of knee stability. All right, so let's say they are a non-coper, they elect for surgery, they meet with the surgeon, and the surgeon is going to discuss graft options with them. So it's not really our role as a PT to discuss graft options with a patient. Now, some patients may ask you what graft is better, which graft should you get, that type of stuff. And these are some key principles right here that are fairly well established in the literature. You're accurate to say that an allograft from a cadaver has a little bit of a higher re-rupture rate in younger athletes, right? So maybe it's not as strong as a graft. The likelihood of it re-rupturing is a little higher. You are less worried these days of cadaver allografts causing infections and viral infections. You're less likely to see rejections. They have improved. These tissue bank companies have gotten so good at the processing of these cadaver tissues that it's less of a concern these days. Although it is a concern sometimes, right? The body could reject it. You could have some type of viral infection. That doesn't really happen with much frequency nowadays. The good news about the cadaver allograft is if you're a little older and you end up getting an ACL repair, it actually has equal re-rupture rate to the autograft. So the autograft is obviously the person's own tissue. You're going to take your own patella tendon or your own hamstring tendon, and that's going to become your ACL. Problem with that is you're taking healthy tissue from your knee, and now you've got donor site morbidity, right? So where they cut the patella tendon out is obviously going to have to heal. That's going to be painful. That's going to slow the rehab down a little bit. Same deal with the hamstring tendon. Good news is they are a little stronger. They tend to do well. Probably for the most part, it's I guess the more popular graft, and then you can also have double bundle. So what people are trying to do now is they try to reproduce the two bundles of the ACL, and they do these double bundle ACLs. Still not the most common way to do it. It's technically more challenging. There's some debate about whether it actually helps knee stability or not. But there's all sorts of little nuances, little surgical techniques that people are doing that increase stability of the knee. You'll see these anterior lateral capsule reconstruction, and they'll suture down different parts of the capsule to try to maintain or improve that stability. All right. So one way we're going to do this is really cover the principles, kind of the key guiding principles. And I'll give you guys a nice resource afterwards that is a published protocol that is a really current, up-to-date, generalizable protocol that if you don't have a protocol would be a good one to use. It's valuable to use protocols for these conditions because we really do need to see certain milestones achieved before we can move people on to the next phase. And so that's why the protocol is valuable. If you can get them in before surgery, that's best practices. It is best practice to have the patient come in pre-op, right? At least 3 weeks. 3 weeks tends to be kind of the sweet spot. And what you do during that time really is try to get that joint back to its normal state, meaning you're reducing the joint inflammation, you're reducing all that effusion, you're reducing pain, restoring that range of motion, getting that quadriceps back, getting them walking normal. You want that person to walk in to the OR, or get wheeled into the OR, I should say, with as normal of a knee as possible, right? That maximizes outcomes. When a surgeon has to operate and repair on a knee that is already incredibly swollen, the quad's already shot, they've already started to stiffen up, those long-term outcomes tend to really be not as good. So anyway, pre-op is key. Blood flow restriction pre-op, that's a good question, Jacob. Honestly, don't have any experience with blood flow restriction in these patients. I know it's gaining popularity. I'm eager to see, that type of a thing and how that can help. I'm eager to see more data come out about how that can help. It makes sense, doesn't it? Right? You really got to battle that quad atrophy. That's quad starting to shut down. If you can get that quad, back to full strength pre-op, you're probably going to do better post-op. So I know it is gaining popularity post-op. I just haven't heard specifically about it pre-op. That's a good question. All right, got to communicate with your surgeon. Hypertrophy. Well, okay, so here's the thing. So the question is, how long do you get to see him pre-op and get the hypertrophy and all that? The thing about it is with pre-op or just with arthrogenic inhibition. Let's talk about the topic of arthrogenic inhibition for a second here. That patient is starting to lose their quad contraction because of pain and swelling in the knee. When you get the pain and swelling to go away, you really can oftentimes restore that muscular strength. So it's not the atrophy is occurring in a very short time period, meaning you will restore that strength and hypertrophy of that knee in a relatively short time period. So anyway, there's definitely a nervous system component to it, and I think that's a lot of times what you are targeting. And it may be that when you target that nervous system like that, that the BFR does that as well. I mean, my understanding of BFR is that there's a hormonal component to it, but it also could be a nervous system component. I really don't know enough about it, but protective due to making tissues more resilient, to being under the tourniquet during surgery. That makes a lot of sense as well. So everybody knows you have a tourniquet around your proximal hip during surgery to reduce bleeding in the joint. You're doing BFR, and Jacob's calling it preconditioning before the surgery to get them ready for that tourniquet, pair those tissues, make them more resilient. That makes sense to me. It makes sense to me. It's new. I mean, that's a new concept, so it's pretty cool. All right, got to communicate with your surgeon. Must communicate with your surgeon. That is critical. If you are getting a patient and you have not seen a patient from this surgeon before, I would certainly take the time to go shadow that surgeon, develop a relationship. I've told you guys this before, at least in year 2. I know I mentioned this in a lot of these different talks. In my opinion, there is no better marketing technique, right, for a traditional PT practice that takes insurance, that relies on referrals. There is no better strategy than going and shadowing the surgeon. Watching a surgeon perform surgery, you're going to be more knowledgeable about their style and their procedure. You're going to be able to communicate that to the patients. You're going to obviously now have a rapport and a relationship with that surgeon, and you guys are going to be friends at some point. So, that down the line is going to maximize your patient outcomes. It's going to get you more patients, and it's going to give that surgeon a PT they can trust, that they know the skill set and all that. So I can't stress enough how important it is to do that. But you want to know, an ACL is not the same, right? No two of these cases are identical. You want to know about the tissue quality. You want to know what that knee looked like on the inside. Rarely is it ever an isolated ACL injury, right? Most of the time, there is an associated, there's associated pathology there. There's a bone bruise like we talked about, meniscus tear, MCL sprain, LCL sprain, popliteus injuries. There's so many things that can go on in that knee, articular cartilage injuries, and you really want to learn from the surgeon, what that knee looked like and how that'll impact your rehab. The post-operative report is critical. You want to read that if you can't get a chance to talk to the surgeon, for sure. And everybody's got a little bit different protocol, right? What I'm going to present to you today is really based on my understanding of the published literature, all the resources that we have that are out there, and then my clinical experience. But that protocol might not work well for a surgeon in your area who has a different approach or different preferences, has different concerns about tissue healing. So there's all sorts of differences. Very hard to make this cookie cutter, but here we go. We'll give it a shot. All right. They're going to come to see you within about the first week post-op, and that is important. You want to get them in as early as possible, right? The earlier, the better. They're going to come in with a brace, obviously, around the knee, And then underneath that, they will have a big fat ACE wrap wrapped around the knee. And that's just to reduce the swelling. There's going to be, some bleeding coming from the suture sites and stuff like that. But that brace is either going to be a straight leg brace that doesn't move, or it's going to be one of these Bledsoe braces like you can see in the picture here. So the Bledsoe brace is also called a drop lock brace, and you can lock this at any angle you want. Now, they will post-op almost always lock this, obviously, in full extension. What you can do as they progress later on is you'll lock it at different angles. So you can lock it so that it'll go from extension only to 30 degrees of knee flexion, only to 60 degrees of knee flexion. And you'll do that later on, a couple weeks later on. But in the beginning, it'll be locked in full extension. The reason for that brace is so they don't fall down, right? That's really the real reason. It doesn't actually force knee hyperextension. It doesn't give you the necessary hyperextension to have a successful rehab. So it's not a device to create a stretch so much as it is a safety thing, right? That's why you got to have them wear it when they're not in the clinic, obviously. So they're going to wear it at night. They're going to sleep in it. They're going to wear it when they're walking. They're going to have crutches on. And the whole goal, like I said, is so they don't fall down and fracture their patella, right? If somebody were to not wear the brace, not be compliant, were to fall down and fracture their patella on top of an already trying to heal ACL, you have a nightmare on your hands, both from a surgical and rehab standpoint. So it's of critical importance, obviously, that they don't fall down. They'll progress. Weight bearing is tolerated over the next 2 weeks. The first 2 weeks post-op is like almost the most critical time. Can't stress that enough. The early time, actually, I'll stretch that out. The first month after surgery is probably the most critical time that you have to make the right decisions at the right time and recommend the right interventions to not screw this person's knee up for the rest of their life, right? What you do in that first month will also make, obviously, the next set of months go much, much, much easier from a rehab perspective. I reflect on the ones that I made mistakes in that first month. Those were all really bad nightmare-type rehab situations in the second, third, and fourth month. As we progressed, we struggled because of mistakes that we made early on. So here it goes. All right. Principle number 1, you must gain full knee extension. All right. Now, full knee extension is technically symmetrical. So if your uninvolved knee, your non-surgically repaired knee is hyper 5 degrees hyperextension, then you got to get that surgically repaired knee to 5 degrees of hyperextension. So 0 won't cut it. You got to get them symmetrical, right? Now, the first 2 weeks, that won't happen. Your goal within 2 weeks is to get them about to 0, and then after that, you push a little further. But this is really important because a stiff, semi-flexed knee is a knee that is going to wear out and degenerate incredibly quickly, right? So you can have more focal force, focal wear on the knee joint, and it won't last. That knee won't last. So that person's going to have a lot of problems if they don't get knee extension back. If you don't get it back early, you end up getting scar tissue buildup. So on the right here is one of our revision cases that we had where the patient actually had a small cyclops lesion. So she retore, and then after she retore, it may have been after, may have been before, it's hard to say, but she developed scar tissue in the anterior aspect of the knee right in front of the graft. So this is it on an MRI right here. ACL graft sits right behind, right here. And this cyclops lesion is a big mass of scar tissue that will sit in front of that graft, that new ACL. That'll limit your knee extension a lot, right? It'll limit it a lot. And so you don't want that to happen. You got to get them going. Well, techniques, obviously, we're going to stretch, right? Low load, long duration stretching is really the recipe. You want them sustaining these positions with their heel propped up, knee hanging into extension. Nothing underneath the knee. Got to hang that knee into extension for about 15 minutes, 4 times a day as a minimum. You want, this is kind of a nice arbitrary 60-minute per day total. It would be a target. This may be poorly tolerated. immediately post-op, and so you're going to want to teach them heel slides, teach them strategies to kind of do this in a more intermittent fashion. So if they can only tolerate 3 minutes at a time of hyperextension stretching, that's okay. They're just going to need to do it with high frequency, right? You can use gastroc stretching is great with a towel, hamstring stretching like that. He's got the brace on, so he's nice and safe. These are all great strategies to try to improve extension like that. A lot of people will put a small weight over the distal femur, right, to just weight that down a little bit and give you a little better stretch, and I think that's good to do. Watch the foot angle. What most people will do is they will externally rotate their hip to try to make it feel a little better. That puts more pressure on the posterior lateral quadrant and doesn't give you as good of a stretch. You really want to try to fix that foot if you can. I've seen these, I don't have one, but I've seen these foam wedges and stuff like that that'll hold your foot in a neutral position, and that may be beneficial if your patient's struggling to keep that hip in neutral. A couple techniques that you guys can do in the clinic. You are certainly going to want to integrate patellar mobilization, so just grabbing that patella, moving it in all directions. That's nice to kind of prevent scar adhesions and stuff. Your patella is basically surrounded by joint capsule, and all the recesses of the joint sit medial, lateral, superior, and inferior to that patella. Those recesses will fill with fluid, and they can scar down sometimes, and that'll create a loss of mobility. So for the first 2 weeks, spend about 5 minutes each session mobilizing their patella. Some people will teach the patient to do it if they think that's helpful. I have found in the patella bone tendon bone cases, so if they had an autograft patella tendon, mobilizing the patella like that is kind of nice too. It dissipates that patella tendon pain, kind of helps that mobility of that healing patella as well. Here's one of those passive extension stretches you can do from when they're in the clinic. You guys have probably seen that one before. I know I show that one a lot in the case of the stiff knee OA. You're pretty gentle with it. It's a finesse type of a thing. You're not forcing that knee. You're not creating a ton of pain. I mean, I would say the more pain that I've created, the worse my outcomes, right? If I can kind of stay under that pain radar, push them a little bit, just kind of nice and easy, ease into it with finesse, the better they do. You're not going to drive flexion, prone pillow. I don't know what you mean by that, Ryan. Prone pillow under the, maybe you mean under the distal leg or something. I don't know. Let us know. Give us more detail. I'll share that with everybody. But to avoid ER, right. So their leg is sitting in a pillow. Oh, I know what you mean. The prone pillow that you use has a little divot in it. You just use that to keep their leg kind of straight. That makes sense. All right. For flexion, you are going to not push them super hard, right? You're not going to push them super hard. Flexion will flare up the knee. It's a swollen knee. It's a painful knee. The more you bend it, the more you kind of stress it out. So what you're going to do is let them be in control of flexion. Heel slides, obviously, are great. They're in control. You can let them do a little overpressure with the heel slide like that guy has with the towel around the foot there. But I don't typically stretch them. I don't recommend stretching them real hard into flexion because in my experience, same thing, flare them up. And flexion comes back. It comes back on its own. As the knee calms down, it'll come back. Got to get rid of the effusion. The effusion and the pain, it really is key. The pain meds are valuable post-op. They really are. So, we're really anti-opioids these days, and I'm certainly, on that. But that week after surgery, they have a lot of knee pain. The more you can kind of get them comfortable and get them pain-free, the more they'll be able to work extension, the more they'll be able to work the quad. You're going to get a lot more done if they're in less pain. So you want to really get rid of the swelling. It can't be a hot knee. A swollen knee 1 month, 2 months post-op won't do well. It's a prerequisite, right? So you can see 2 weeks out, that's a hot knee. And it's going to be hard to get the quad going, hard to get extension going, and it's going to slowly calm down over time. You do everything you can to really accelerate that process, right? I mean, I would say this and getting the extension are your two big priorities. Some people like, they'll have that ACE wrap on and they'll keep it on for a while. They'll like the ACE wrap and they'll get good at wrapping it. Obviously, with a gradient, pressure gradient change, right? It's a little tighter distally as it moves up to kind of try to push that fluid proximal. And then once they're done with that, get them a sleeve. Recommend that they get a sleeve. You really want compression on that knee almost on a constant basis in the month post-op to get that swelling out as quickly as possible. And then tons and tons of ice. 15 to 20 minutes every hour on the hour. The 2 weeks that they're sitting around because they're not doing a whole lot, they're off work or they're not at school and stuff like that because they're still trying to recover, they got to be icing constantly. Intermittent, frequent ice is really, really important. All right, you're going to try to normalize gait. Try to normalize gait. You really want to do this as soon as possible. So, they're going to be weight bearing as tolerated for a while on the crutches. When they sort of wean themselves off of that and they start to get away from the crutches, it's going to be sometime in the first 2 weeks usually. That's when you're going to want to start working gait. The treadmill works so incredibly well. So if they're allowed to, and this is why that surgeon communication is important, because the surgeon usually will have specific time points that they'll want that drop lock brace adjusted. So talk to them about it. But if they're allowed to unlock the brace and walk on a treadmill with it, this just completely takes the limp out of their gait. So that moving platform, that belt from the treadmill, forcing that kind of symmetrical, reciprocal gait pattern really works nicely to get the limp out of the gait. You don't want them limping around 4 weeks, 5 weeks post-op. That's a delayed recovery, delayed rehab. You want them getting normalized gait soon. Got to get the quad back. Got to get the quad back. So early E-stim, obviously Russian stim. These are the larger rectangular pads. Put them over the motor points. We'll typically move these around till we get a nice strong quad contraction. We want to see a quad contraction. And you got to crank the intensity up as high as they can possibly tolerate to get as strong as a volitional contraction as possible. So because of arthrogenic inhibition, they won't be able to voluntarily contract that quad usually in the first week or two post-op. And the Russian stim gives you that. At some point in the beginning, you just do it with quad sets. You'll eventually integrate it with straight leg raises, usually at least a 2-second ramp up, so that it doesn't come on and shock them real fast. You want it to ramp up and then, sustain hold. Usually it's a 10-second on, 10-second off, intermittent. You can progress it to longer hold times and shorter rest times as they get better and better. And then we'll do it with abduction exercises as well. So working the hip and glute med while that knee is locked out with the E-stim. All right, more quads activation type stuff. So one important thing to remember is we don't want active open chain knee extension, particularly past 40 degrees. So from 40 to 0 is been shown to put stress on the graft, on the ACL graft. And obviously you don't want that. So you're going to try to do a lot of closed kinetic chain or knee locked out type of exercises. It's nice. I love the prone because it really teaches them to kind of lock that knee out, get the quad going and lock it out like that. They can also contract and supine like that, push into something, push into a towel. Oftentimes you're here providing tactile cueing to the quad, having them push into your hand. You can do it in standing with the band like that, terminal knee extension, just working that. It's okay because it's closed kinetic chain. It's not going to put stress on the graft the way it would in an open chain environment like that. Straight leg raises are a critical post-op ACL exercise because you've got to get that quad back, right? Quadriceps strength deficits will linger for a long, long time post-op ACL, and you want to stay on top of it early. So early straight leg raises. I'll really do a ton of isometric holds in varying angles. I am not a fan of a standard just kick the knee up, bring it down, kick the leg up, bring it down, fast straight leg raise. I want isometric holds at every different angle. I want them to hover that knee above the table, really lock it out, strong contraction, that type of stuff. You don't want any lag, right? If you see a lag, that's obviously because the quad's not doing its job and you want to correct for that. Give them some type of assistance so they can accomplish it without a lag. All right, so we're past 2 weeks now. So this program that I'm describing now is really a combination of both a criterion-based progression, and then you have certain time frames that you can expect. But it really shouldn't be a time-based progression. Time helps us understand kind of where we are as far as tissue healing goes, but you also have to remember everybody heals differently, and then the concomitant injuries are going to influence that. So time can be challenging. This is what we need to see, though, to get people into this next phase of rehabilitation and do these more advanced exercises. We need to see good quad control, meaning they can do a handful of straight leg raises without a lag. They can activate that quadriceps, volitionally, isometrically on their own without requiring E-stim. They should have full mobility for knee extension. It's at least going to get down to 0. Don't worry about flexion, like I said earlier. As long as they got 90, they're good. And then you can see all the other stuff. But this is a calmer knee. This is a knee that has started to heal a little bit. We can get a little more aggressive now, which is nice. You want to work isolated proprioceptive type of work. So these are knee, you guys have seen me talk about this before, joint position sense from a testing, procedure. This is what you would do as far as have them with their eyes closed, extend the knee. Remember, not going past about 40 degrees, it would be a little too far. And they're going to hold different positions. And you're going to train them to hold different positions. It works really well to do this bilaterally at the same time. So you're going to extend both knees, and I want both knees to match in the position that they are able to assume. So it's kind of like position retraining. It works great with a mirror. So you can do this the same way you would with graded motor imagery or mirror therapy, where you're going to have them with that healthy, non-involved knee right here in the mirror. They're going to do heel slides with that knee. And the other knee's doing heel slides at the same time, but they don't see the other knee. They don't see the ACL knee. They only see the good knee looking back at them in the mirror. And that's a nice little joint repositioning technique you can do to help improve proprioception. So remember, the ACL, the old one, had mechanoreceptors in it, right? The new graft doesn't have mechanoreceptors in it. You just have tissue with no nervous system input role. So they're still going to have proprioception of the joint, obviously, all the other proprioceptors around the joint, but it won't be the same. So that needs to be part of the rehab process as well. You can get them on the bike if the range will allow it. The bike is great. You get that nice reciprocating movement, healthy, fluid movement for the joint. There's an endurance component to it. But I would say if they can't do it, they can't do it. Don't push it, right? What'll stop the bike from working would be a limitation into knee flexion. So if they don't have great knee flexion, if the knee is still too swollen, they won't be ready for the bike yet. So wait on that until they can do a full. Now, some people will do like half revolutions and stuff like that with the bike just to get a little self-stretch and stuff, and that's fine. I mean, I like heel slides just as much, but that's fine. And then leg pressing. Leg pressing from a graft stress standpoint is okay. Even if you have a moving platform like you do here, which I think you could probably argue in a little bit is open chain, but it doesn't put stress on the graft the way open chain knee extension exercises do. So leg press is great. You can control, you can dose it very specifically. You can work leg press from a progressive loading standpoint. We use leg press. We don't have, so if you don't have most clinics aren't going to have an isokinetic machine. You're not going to be able to measure quad strength with any accuracy. So what you can do is use the leg press. Even though it's obviously compound movement for the lower limb, it's a great way to try to determine symmetry of strength between the two limbs. So that's a nice little trick from an assessment standpoint to see, what's their 10 rep max on the uninvolved limb versus their 10 rep max on the involved limb, stuff like that. All right, we're going to get them squatting. And that's important because of the approximation of the joint, weight bearing through the joint. So there's a proprioceptive input. We like weight shifts, get them to start putting weight through that knee, and then mini squats to start. Obviously, they're going to hold on to something that helps them with that kind of sit back movement, keeps them safe, keeps them confident. I'd rather them do squats in a safe, confident environment then stress them and challenge them and have the squats not look all that great. So, sometimes less is more. Smaller flexion angles are okay. You're just gonna slowly progress that, right? But obviously it's a great way to get the quads going. Stepping exercises are critical. We got to get them used to putting weight through that leg, and we really want to get them used to putting weight through that leg in a single leg stance type of fashion, right? So these cone stepping drills are kind of nice for that. That's a good one for restoring gait. She works that hip, bringing it up into flexion like that. It's kind of nice. And then that step through, that weight transfer is really key. That's a great exercise for that. Single leg squatting progressions. You can single leg squat as soon as they can tolerate it. And if they don't have a bad bone bruise and they can tolerate that single leg squat, in a controlled environment like that, that is actually a great early exercise. So I'm okay with them, just going down 15, 20, 30 degrees in knee flexion. Still going to get good engagement of the quad and glutes, and then working on stable surfaces and progressing on stable surfaces. This is towards the end, now of that kind of early phase. There's a lot of benefit to standing on unstable surfaces just because of the co-contraction. The co-contraction, the neuromuscular recruitment that you get from that is really nice. You can see that there. There's all that muscular fasciculation and just fatigue that's occurring, right, because we're on that unstable surface. Stepping exercises. So coming up on a small step, we'll progress step height, but that's another nice closed chain one, getting great quad and glute and hamstring gastroc control. Side stepping. Remember, with the female athlete, they tore, if they did tear due to hip pathomechanics, lack of core control, lack of hip control, and we're going to start getting on that early, right? We only have so much time with them before we send them off to the next professional, the strength and conditioning professional, and so getting the hip going early is valuable. Love sidestepping exercises like that with resistance to the hip external rotators and abductors like that. I'm going to work some slow kind of eccentrics for the stepping maneuvers, right? These are nice control exercises. Can they isometrically hold? Can they control their weight? Building endurance and control and proprioception in a closed chain environment like that. In this case, we are really concerned about hip pathomechanics and the hip dropping down. So the exercises like this, we are constantly looking at the hip, constantly looking at the Trendelenburg, which you saw a little bit there at the end, wasn't too great. We want control of that weight-bearing hip. We want that glute med to really see. Now that's a hike. That's a bit of a compensation. I'd actually much rather have that be a nice level pelvis, and we're isometrically controlling that glute on that side to keep it down, as opposed to over-exaggerating like that. All right. So things start to honestly get kind of easy after month number one, easier after month number one, because you're not as protective of everything now, and you're starting to get to a point where it's a lot of traditional strengthening stuff that really are very similar to any other type of rehab that you would do. So they're the criteria there. I mentioned the leg press as a way to kind of compare strength. I know it's not a direct measure of the quadriceps, but in a lot of cases, it's the best thing you have. You could do straight leg raises with different cuff weights and compare those to the other side, but you need some type of objective way to determine quadriceps strength. And without an isokinetic or a handheld pressure dynamometer, it can be quite challenging. So the exercises, the number of repetitions, and the load is your next best option. All right, we got to get them going from an endurance standpoint, right? And this UBE, I mean, I've seen people use the UBE week 1 post-op just to get their heart rate up. So think of all the benefits of cardiovascular training, the nervous system, the hypoalgesic effect you get from the nervous system. So if you were worried or they couldn't take a lot of pain pills afterwards, getting that heart rate up is incredibly valuable. And they're going to be deconditioned from laying around a lot and from just the time since the injury of not doing a whole lot. And so you want to get them back to that. Love the stair stepper. The stair stepper is great because this is a cardiovascular exercise, but really working. It's a great quad, glute, posterior chain, gastroc exercise, obviously, as well. So if you have access to one, that's a nice option as well. We do a lot of perturbation type stuff, a lot of neuromuscular training drills. So it really like these semi-squat, different angles. So just a soft knee, an unlocked knee, going deeper like you see here at about maybe 45 degrees of hip and knee flexion, getting really deep as they can comfortably get down into that squat, and then working an unstable surface to try to get some perturbation to the nervous system and to those lower limb muscles. Eventually, we're going to have them squatting with weight. Eventually, we're going to do different techniques to kind of tweak their squat form. Maybe them holding on, and maybe them standing in front of a wall like that, having to keep more of an upright trunk, right? Load those quads a little more. The more you get that trunk folding forward, the less you tend to load the quads. So what they'll do when they're weak is they will fold at the trunk, hinge at the hip a little more, and you can kind of target the quads a little better by this little trick here, having them do it in front of the wall like that. And then load it. If you don't have barbell in your clinic, you at least want to load the squat with a goblet-style dumbbell, kettlebell. Got to get some weight in their hands and start getting them squatting. And we'll do a lot of single-leg squats as well with weight, which is another nice way to load them up if you don't have a ton of equipment. Working that hip, obviously super important. This is a nice active hip abduction exercise. The top leg is up. This would be his involved, his left. Although I would encourage you to consider, do a lot of this stuff bilateral, right? They've got a lot of contralateral weakness. So if you have enough time with them, then you might do a lot of these bilateral. But anyway, the other leg is up. This is a nice left glute med, involved glute med, QL, core control type exercise. Sustain holds, perturbation, sky's the limit, right? How you can challenge them there. Love this because now I'm getting the quad. I'm getting the core. It's just a nice overall, all around kind of whole body sort of stability control exercise like that. Lots and lots of perturbation training. However you want to do that. You want to toss basketballs to them, throw things at them. Having them rotate is key. Right, that ACL is a rotary stabilizer of the knee. So having a semi-flex knee, I want them to twist that upper body on that knee to create knee stability, simulate that knee stability like that. Going to work really all the muscles. It's everything from the core on down, right? So a lot of heel raises, a lot of hamstring work. Sky's the limit here. Whatever setup you have in your clinic, you'll be able to integrate. People do all sorts of different hamstring strength exercises. Hamstring strength used to be real popular. People say, oh, the hamstring prevents anterior translation of the tibia, so I'm really going to hammer hamstring strength. It does prevent anterior translation of the tibia, but it probably doesn't stop the ACL from tearing. You could have incredibly strong hamstrings. You're still going to tear your ACL if your hip mechanics are pathological or you fall into that risk factor kind of category. So hamstring strength is important, but it's not the end-all be-all, certainly not the primary focus. All right, getting towards the end here. So now things are really going to get unique based on that individual specific sport, what they're getting back to, all that stuff. So what you get in this kind of advanced phase really is a precursor or preparatory to what they're going to do in their return to sport phase. You can see the criteria to be in that phase there. This is a knee that's getting pretty back to normal in a lot of ways, right? They almost look like a Coper in a lot of ways, and they're all going to want to know when they can run. It's like the most common question you're going to get as you get towards this time of the rehab. When can I run? You see a lot of people run at week 12. You see a lot of people run at week 14 or week 16. The good answer, and one of a research paper that Kevin Wilk published, he said, you run when you're ready to run. You run when you're ready to run. And what he means by that is you run when your knee looks like it can run, meaning it's got no swelling, it's not reactive, your quad is strong, and you run and you tolerate it. The worst thing that can happen is they start running too early, they flare up, they swell up, and then it slows you down, and you're like going back a couple steps in rehab, right? So sometimes better to wait a little bit, make sure that knee's a little calm. And most of the time, the surgeon, makes the call, because the surgeon really is the driver of where that knee is from a tissue healing perspective, and so you want to let them kind of be in charge of that decision. Return to sport phase, or as you get ready for the return to sport phase, obviously you're going to have to integrate a lot of plyometrics, higher level jumping exercises, landing. We need to teach that co-flexion of the hip knee. You probably never got that patient pre-injury, right? So they never really received any type of ACL prevention program. They never learned how to land. They never learned how to cut. Now's the time you can start doing that, teaching them soft landings and control, looking at hip pathomechanics, making sure all that stuff's squared away, when they're ready for it. And then you want to integrate speed. That's really important. You're going to want to train them when they're tired. I love this drill to wear people out. So I'll say, let's see how many foot taps you can do in 45 seconds. And they'll get and we'll do maybe 3 intervals of that or 2 intervals of that. They'll get kind of gassed, and then we'll do some of their control type exercises, plyometric type exercises. So I want to get them ready for that situation where they're back playing sports and they're tired and the hip mechanics aren't as great as they could be when they're fresh. So consider fatigue, that's important. And then these are all the activities you're going to end up having them do. Running with sports cords, doing different speed drills, change direction, obviously, tons of landing, like I said. And then it's a very standardized progressive strength and conditioning program, right? You're going to get a lot of core work, a lot of deadlifting, a lot of hip work, a lot of quad work. This is a year-long program. It really is. Hopefully you get to see them after you're done rehab and you see them in some type of strength and conditioning format, or you refer them to a strength and conditioning professional that you trust and that has good experience with strength and conditioning in this population. That is it. That is it. I'm going to, like I said, give you guys this as a handout as well as a paper. I'm going to give you 2 papers, one on prevention and one on the basics of ACL rehab, both newer publications as just resources for your library. Any questions, comments? Feel free to unmute yourself, chime in.
Eric, I've been getting patients. We have the MSU sports doc up here who does a lot of ACL research, and he's been pulling his patients out at 6 weeks post-op because that's when the grafts are the weakest, and then having them go home and sit for 6 weeks and then come back to PT, which seems terrible. What do you know about that? What do you think about that?
It's unconventional. The graft goes through a remodeling process in that 6 to 8 week time frame. But if you're not doing anything that would tear an ACL, that makes sense if you don't trust your PTs, But anyway, this you do not dial back because you're in week 6 or week 8. You are always protective of the knee joint. And that entire program that I showed you in nature is protective of the knee joint. So that's unconventional, but at the same time, maybe they've had a lot of re-tears in that time frame. I don't know.
Yeah, so they've been coming back with more pain and loss of range of motion, kind of what we would expect from going back to sitting on the couch for a couple months.
Yeah, and I guess then you got to ask yourself, what's the downside of having them in rehab but having a more conservative protocol? Where, in the first 10 weeks per se, we are more conservative than the way I just described. What I just described is honestly not even really I guess you could call it the accelerated protocol. Nowadays, all protocols are accelerated. We used to say that that there was like an accelerated protocol and a delayed protocol. if you have somebody with a ton of concomitant pathology and maybe is very, very deconditioned, they probably wouldn't get as accelerated of a program. But anyway, a friend told me that after a previous ACL tear over a year ago, recovered now. Her P told her, yeah. Okay, that's a great topic. I really appreciate Mario bringing that up. So the knee extension machine, right? Seated knee extension open chain exercises have been demonstrated to put more stress on the graft. And it's rare that you would see anybody during an ACL rehab to work knee extension all the way out to 0. But what you can do, and what almost all protocols will advocate for, is go from a flex knee position of 90 to about 40 degrees. Now, early on, you do about 60, you do a shorter range, and then you progress that up a little bit. But yes, open chain knee extension, especially at the terminal end of knee extension, can be stressful to the graft. You will see people that won't do it for a year. You got to think after a year that knee is somewhat normal again. They can do it again. I have heard of surgeons say you should never do it. You should never do knee extension open chain again. I know that's debated. I guess the key would be, are there other exercises you can do to keep the quads going and get the quads going? Can you avoid that exercise, because there's other stuff? When do you start? Is this a true thing? When you start typically doing open chain terminal knee extension, long arc quads against resistance, you won't see that all the way to 0 in many protocols. You might towards the later phase, the return to sport phase. In the first 3 months, it's very rare that you'll see somebody advocate for knee extension all the way out to 0 in an open chain. So that's why we use so many different closed kinetic chain exercises. See your patients back after refer on to a strength coach to perform return to sport testing at regular intervals. That is so critical. So Tommy, that's a great question. Would you have people come in and test them? Absolutely. Absolutely. I mean, it depends on what your setup is, but we're not doing enough objective testing throughout the return to sport phases. And so it's like the quad symmetry stuff, the hop test, the agility test, those are critically important. It's oftentimes a surgeon's decision based on, really basic information. You got no pain, the knee looks pretty good, and it's been 6 months or 8 months or a year. You can go back now, as opposed to putting them through a battery. When you look at these center of excellence, these places that are centers of excellence for ACL rehab, Cincinnati Children's Hospital being one with Hewitt in that group, that's all they do is test people like crazy. I mean, they're testing them constantly throughout the criterion base. The paper I got for you guys, I'm going to I'll give it to Alan here and he'll post it for you, has a really nice checklist for return to sport testing and criterion-based testing that you can use. Is quite nice.
Eric, I have a question for you. This is Amy.
Hey, Amy.
So with some of the ACL prevention programs for women for non-contact injuries, the number needed to treat is quite high. I think I've seen between like 70 and maybe over 100. So I've heard that used as an argument to not do a prevention program, saying, well, the number needed to treat is so high, is there really a benefit? So I guess if you hear that argument, what could you use to counter that or persuade?
Well, economic impact and resources, right? What's it cost to go and educate a coach, or to even for a PT or a strength coach or a trainer to go and work with a team, But the thing about this stuff is it's so incredibly basic, and it's like, if we can teach you this as a 10-minute strength and motor control intervention that you can do as part of your warm-up or part of your in-season training, what's the downside? You know what I mean? So to me, it's so cheap, it's so easy, and it has such, it just makes too much sense to not do it. if it were expensive, I could see that rationale. But I think because it's so cheap, that's a hard way to. I mean, what I like, if you got an established private practice and you're busy, that's a different situation. But if you're new in town, I mean, I'd go and I'd do them as a service to the community. You're going to get your name out there, and you're going to do them, become thought of as an expert in town, and you're going to get more busy and more patients just due to that. So anyway, I don't know. What do you think? You see a lot of athletes. What's your kind of perspective on it?
Are you asking me?
Yeah.
Oh, no, I don't. So that's what I was asking. Because there had been that, I've heard that argument, or, the coaches will say, we have so little time, and there's this, is this really going to be benefiting us to do this? So that's why I was really asking your opinion, because I've heard that argument. To me, it seems like it would be a common sense thing, but.
Yeah, and you know how it is, with coaches and stuff. I mean, but maybe it's early. Maybe we got to target an earlier age group where it's not as competitive. They're not worried about, I don't know. It's just too, I guess you got to get the coach that's lost 2 or 3 athletes. That person's going to be a lot more receptive than the new coach that hasn't been around long enough and hasn't seen the detrimental effect that it has. And to me, a 70, 100 individual number needed to treat is kind of nothing. Like, I'm envisioning going out to a soccer club that has, 12 different teams and hitting the entire program. And I still think resources needed for that are not too bad. So that's cool. ACL prevention clinical practice guideline. Yeah, I saw that came out last week, I think. So if you haven't checked it out yet, JOSPT has it's like exercise interventions for ACL, knee ligament injury prevention, clinical practice guideline. So thanks, Tommy, for bringing that up. It's a good point. I looked at it and I found it to be not as clinically applicable as this. I'm going to give you guys another paper on it that I think is a little more clinical. It kind of gives you more resources and shows you better. They have videos. That's cool. On JSP website. I'll have to look at that. That's cool. Yeah, that's good to know. We'll link to that one as well, that JSPT CPG. Yeah, FIFA 11 Plus is definitely where it's at. And if you guys click on that link, this court group right here for FIFA 11 Plus, that's actually a handout. That's actually a PDF that teaches the athlete all the exercises. It's really well done, great pictures, great detail. That would be a nice one. You could just simply, I guess, in like Amy's example, they say no to you, they won't let you do it or whatever. You just give them the booklet, and at least maybe they can take a look at it. Yes, Phil. It is a slower, so the meniscus repair slows your weight-bearing stuff down. It also slows your knee flexion progressions down a little bit. So that'll be a more delayed. When we were in that kind of week 2, 3, 4 time frame, we had a lot of sort of step-ups. That was one part of it, the squatting exercises. These might need to be done a little more carefully, a little slower. I got to just kind of monitor symptoms. I don't want to put too much stress on that meniscus repair. And then obviously the knee flexion. When they're doing their heel slides, you're letting them be in control. Don't push knee flexion too much. You're going to stay in that mini squat phase for a little longer. But that'll depict, and the key to that one is debridement versus repair, how bad the meniscus tear was, how much they had to repair, and where it was in the horn. So that's another kind of one that, communication with that surgeon is going to be key, because it could, it could vary. Like you said, it could vary a lot. All right, anything else? Anybody else? I'll hang on for a few more minutes. Yep.
I have one more for you, Eric. What are some strategies that you use to help, I guess, redevelop confidence and reduce fear when you talked initially about re-tear or tearing the other side, and so some of those top-down influences. So what are some of the things that you have used or seen that have been helpful?
That's a good question. I don't know that I'm all that all that great at that, but it's all the same stuff that you do with anything else. I guess here's one thing. There's a healthy level of fear that keeps people from maybe doing things too fast, jumping back into things too fast, and then there's unhealthy fear that clearly slows down the rehab process. So, and I'll tell you, healthy fear, in that early phase, like I'd much rather somebody be careful and concerned and they're in the brace longer than they should be. But you know what? At least we can be confident that they're safe. We can be a little more confident they're not going to have an incident. So if I'm going to err on one side in the middle of the rehab and in the early part of the rehab, it's on the side of being okay with a little bit of fear. I think that when you notice it really is hindering the process, you use all your typical pain science stuff. I think it's okay. You might also let them do the exercises in the brace. Let them be a little more guarded. Let them kind of do things in a more protective environment, and let them control things a little bit more. That can be helpful. Where fear really rears its ugly head and where we see fear as an issue is in the return to sport phase. And that might be just that they're not ready. They're not ready, and maybe that's a discussion that has to happen. It may be that, I don't know, that it needs another professional, like a sports psychologist or somebody. But we do know fear increases re-tear risk. We do know that. And so it's probably a good conversation to have with the person, explain it to them, explain it to their parents and all that. We didn't talk about it. It makes me think, Amy, too, is a custom brace. So a lot of people will get a DonJoy, and those braces are debated a lot on whether or not they actually prevent re-tears and whether they actually, create knee stability and stuff like that. But when you talk about fear, sometimes that brace is a difference maker, in that later phase. There, talk about resources and expensive, though. Those things are real expensive. All right, anything else? Anybody else? Last minute comment? You guys can all reach out to me anytime. Facebook, you know what? I'm going to put, all right, this is the best. My email at school is the best one because I check it the most frequently. And I'm not on Facebook a lot. I'll check Facebook periodically. If you message me on Facebook, that is a good way to get a hold of me as well. But if you don't hear back from me, do not hesitate to shoot me a email real quick. If I can get you guys any resources or anything, don't hesitate. I mean, there's one thing that I have. It's a lot of research. So if you were like, hey, I'm trying to develop a new protocol and I need more research on meniscus repairs and healing processes and how to, whatever. Any principle that you need help with, do not hesitate to reach out, and I will get you talk about shoulder rehab at 11:30 at night. That would be fun. I would enjoy that, Alan. Feel free. But anyway, yeah, reach out, hit me up. I'll get you guys anything you need.
All right. Hearing no more, we will shut this down. I'll get all that research in these slides up on the Vice website shortly.
Awesome. Thanks, everybody.